And I'll send this recording out to all the people who are participating tonight who registered for this course. So this is night 2 of our virtual curriculum here at UVA. We had a great time the first night. You know, obviously this is evolution. We've never done anything quite like this before. And so what we want to make sure is we try to maintain a fresh curriculum that you guys will enjoy. We really want to show you a lot about UVA, about Charlottesville, about why we think it's a great place to come and train. So again, like we'll do every single night during this curriculum of 9 weeks, we'll start off with the resident talk about just some aspect of our program. Tonight we'll talk about our town, our hospital, just so you can get like a virtual tour if not. And then Dr. Mark Miller, the esteemed Mark Miller, will give a little talk on ACL tears. He's got a little bit of experience in ACL tears. You'd be surprised how many ACLs he's been doing. Probably ACLs before some of the people on this call were even around. So anyhow, we're looking forward to that as well. Then we'll do a case. We'll break up into small groups and do a case. So during the small groups, I'd ask the participants to put their videos on so we can get a chance to get to know you all. And our residents will lead you guys through some an ACL case and try to just kind of talk about what it's like to be a sports medicine doctor looking at these ACL cases. So without further ado, I'm going to turn the microphone over to my PGY-3 resident on sports right now, Ian Backlund, who's going to give you guys a little talk about Charlottesville and the University of Virginia Hospital. Ian, the floor is yours. Thank you.
Awesome. Thanks, Dr. Guathme. Again, so guys, if you didn't have a chance to meet me last week, my name's Ian Backlund, one of the PGY-3s, again, giving one of the resident life talks on Charlottesville and the University of Virginia Hospital. So excited to give this talk. I was a rotating med student a few years back and really fell in love with Charlottesville and what it had to offer. As Dr. Guathme alluded to last week when we had our other talk, Charlottesville is a small town, but it's got a lot of big town accommodations, a lot of things to really love about it, which I think is really sort of a Goldilocks phenomenon for residency. Again, finding a place that has accommodations, but is certainly small enough to where you don't get lost in the weeds for a little bit of time that you have off. So fantastic place to live. It's voted one of the happiest places to live in several magazines quite frequently. So you see a recurring theme of, a lot of people agreeing that it is a great place to enjoy residency. And even if it's not a place you plan on living long-term, it's certainly an endurable environment for 5 years of residency for both you and your significant other if you plan on bringing anyone with you. So this is a picture of the downtown mall. You can kind of see aerial view. This is Fridays After 5. Just one of the things we'll sort of get into as we go through. So Virginia, as you know, we're sort of nestled in the central northern portion of the state and service a pretty wide area. To our west, we have Skyline Drive and the Blue Ridge Mountains, which are about a 30-minute drive to a lot of different hikes and outdoor accommodations. And then DC is basically about a little over 2-hour drive to our northeast. And then Richmond, the state capital, is about a little over an hour. And then you're about 2 hours to the beach as well. The thing I really like about Charlottesville is the climate. So I grew up in the upstate in South Carolina, which is very hot, and we really have basically go from summer to winter. And so you have pretty much a spread of all the seasons here in Virginia, which sort of renew your confidence for outdoor life. I want to get back out there as you see sort of the seasons start to change. So don't have to endure the heat or cold for too long. As you see, our peak temperature, although we're sort of making a liar out of this chart this year, is about 87 degrees, so not too bad. And then we get a cold for a couple of months, but then pretty much snap back. So really nice climate through the majority of the year. We average about 209 days of sunshine a year here in Charlottesville with our rainy days mixed in there. You can see our average rainfall there. And then in the winter, we do average a few snow days. So again, you see a nice spread of all sort of the different seasons as you roll through the year. Again, average snowfall accumulation there. So the thing I really love, as I mentioned, is the season. So again, you can see the grounds of UVA here with the fall foliage coming in. And it's a really beautiful time of year, again, with the weather and the change of season. This is another shot of Skyline Drive, and you see there's sort of peak days for the fall foliage, but people come from a lot of different places to witness it, and it really is quite a sight to see. In the winter, again, we do have a couple snow days, which is usually pretty short-lived, which is nice because the hospital does not take days off. You still have to be in usually, but it's a nice change of scenery for the couple days we have snowfall. And again, you can see the grounds here, the blanket of snow. In the spring, it's really nice as well. So sort of back to those really nice temperatures. And again, you have the eastern redwoods and the dogwood trees that come into full bloom, and it really is quite a sight to behold. This is a shot sort of summertime up at Skyline Drive, and really beautiful sights up there. The summer is nice because even though, you know, we have a high of 86 degrees, it runs about 15 degrees cooler up there. So still a nice day for a hike when you can escape to get away from sort of the hustle and bustle hospital. And there's always sort of a new trail to hike up there. One thing I really like about the summer times here, this is Carter Mountain, which is one of the really neat apple orchard basically up on top of a mountain that overlooks Charlottesville. And they have sunsets at Carter Mountain. So this is obviously pre-social distancing, but right now they're selling tickets to kind of keep the numbers down. But Wednesday and Thursday nights, you can go up there evenings, watch the sunset and hang out with friends and grab a beer. It's a really beautiful sight there. We have several other orchards. So this is Child's Peach Orchard, which is one of many. This is, they also have strawberries and blueberries, as well as apples and peaches. So always some sort of produce to go there and pick and escape with the family. It's about a 30-minute drive from Charlottesville. So in terms of, you know, the big town feel to it, so this is Dave Matthews Band, which was a college band back before they hit it really big. They do come into town occasionally, and the college scene really does bring some nice venues to Charlottesville. So certainly some bigger time events that we have. So this is the football stadium with a concert there as well. Obviously, collegiate sports are a big part of this town with the university. So certainly always something going on to get involved with on that venue as well. One of the nice accommodations people really like is the downtown mall. So it's basically a road that is now closed off. It has a lot of restaurants, bars, and businesses. And many of my colleagues and myself will frequent down there. We'll run into folks from our gen surg service. You know, always a nightlife going on there on the weekends. And then during the week, it's really nice. So that you can see there on the left, there's a lot of outdoor seating for restaurants, and the large trees there offer a lot of shade. So really not a bad day down there when you're able to escape and see a little bit of a change of scenery. But again, it's a beautiful place. One of my favorite things to do on Saturday mornings is this is the open air market. So kind of an aerial shot. I have a lot of local vendors come there to sell artwork and produce, as well as food. And it's really neat to go down there and see what all the different local vendors have to offer and grab something to cook up for dinner. And then again, just adjacent to the downtown mall. This is a shot of Skyline Drive, which really has a ton of hikes. I sort of made a mission to explore several of them, but there's just way too many to even count. So they have everything from waterfalls, so innumerable waterfalls that you can hike, as well as summits. This is Old Rag Summit, which is one of the more popular hikes on the East Coast, and really has some pretty breathtaking summit views as you sort of scramble up the rocks to the top. And again, the temperatures up there are usually about 15 degrees cooler. So really nice just about year round in terms of getting away. So again, Charlottesville really does have a lot of venues to offer. Again, my significant other who joined me up here really loves it here. You know, there's always something to do escaping the city and the hustle and bustle of things to kind of get away and relax, as well as some bigger time accommodations. So certainly a happy place to live with always something new to explore. So we'll get into the talk about our hospital system and what a day is like there. And I think the easiest way to sort of take you through what it looks like is just to show you what sort of an average cycle looks like for us entering the hospital just on a daily basis. So this is a front view of sort of the main hospital before our expansion. And then off to the left, you'll see just a shot of our expansion. So this is kind of the main thoroughfare through the hospital again. And this coming around, you can kind of see the emergency department there on the ground floor, which is a entirely new establishment. It's a beautiful place that has all single rooms, which is really nice. So you're no longer having to treat patients in hallway beds and things like that. So certainly a big step up in the way we treat patients, which we'll show some other picture of. So as you come around the back of the hospital, this is where our ambulance come in. This is sort of where you drive in to get to the parking garages. Also serves as a triage center for mass casualty events. So this is our south garage. So we all have a parking pass that comes out of our salary, and we all park there. It's about a 2-minute walk to the back of the hospital, where you'll find your way into the basement to the on-call suites, where most of us go in the morning to get changed to our things. You have a scrub machine down there, which makes it easily accessible if you're going to be in the ORs for the day to get things changed out. We also have a gym down there. You can see myself and one other individual, which is about the typical number of people in there. So certainly up for grabs for morning or evening workout, which is a really nice accommodation there, only available to residents. This is our call room, nothing too fancy there, but our night float team gets to know this place pretty well. It's usually a second and a fourth year who are on during the week. Almost all your basic accommodations there. A lot of people grab coffee from higher grounds, and they are open very early in the morning and available to get your beverage of choice. And then our sort of central spot is 6 East. So this is our 6 East workroom before we transition to the new wing of our hospital. We'll meet up there to make the list and pre-round and sort of divide things up and see all our inpatients who reside there. So in the bottom left corner of the screen, you'll see Pat, one of our 3 NPs who really run the show in terms of taking care of our patients on the floor. And we also have a medicine co-management team that looks after our medically complex patients and make sure we offer them the highest quality care possible. There's usually, that's a wall there. Usually see some interns up there as well. This is Leo. He's one of our nurses on the 6 East floor. Obviously 6 East behind him there, where all of our inpatients reside, and they do a great job of taking care of our patients there on the floor. Other place we typically round for at least trauma's sake is the trauma ICU. Have a several bed ICU there. And we frequently see our polytrauma patients on that floor, as many of my colleagues will know I'm no stranger to. And then after we round, we typically meet for some sort of conference. So this is a view from our service-specific conference on sports medicine. Again, this is kind of an average view out of one of the windows, and it really is. Charlottesville looks like it's in the middle of a park, and it is. It's a beautiful place. Sort of remind you that you know, there are better days ahead when you are stuck in a hospital for long hours. But service-specific, that's on Thursdays. In addition to that, we have anatomy meetings as well. This is our anatomy lab, where we'll have anatomy dissection at the first start of each rotation, as well as the sort of the topic that we're covering. So for instance, hand or elbow, and we'll do a dissection and kind of go through the anatomy. And as you see, it's really set up just like an OR. So you have fluoro in there, you have all your lightings, your beds, your arthroscopy equipment, and all the tools you can imagine. So it's a great augment to our curriculum, again, to sort of keep us grounded and work on our surgical skills. And then after we have our meeting for the morning, we typically will go to the surgical admission suite here, again, to get our patients signed in and teed up for the OR. We have about just over a 30 room operating suite that's frequented by our spine, trauma, and recon folks, as well as some of our more medically complex patients for what are typically outpatient surgeries. This is one of our average sort of looking ORs here. And then we have our PACU as well, where I'll check on our patients and do some of our documentation and talk with our nurses who take awesome care of our post-op patients until they make it up to the floor. This is the main lobby of the hospital. Again, if you make your way down to get some lunch, this is our cafeteria. So we have some sort of standard accommodations down there, as well as some rotating cuisines. So more of our static establishments are things like subs, our salad bar, pizza, and then again, we have some food accommodations that sort of rotate through to keep things fresh. It's just the seating arrangement there, abiding by social distancing. And then if you find yourself on call, so this is one of our recently used trauma bays. So we have 3 trauma bays in the new ER, which is on, again, that ground floor of the new expansion. And we will have 3 additional ones once we're done renovating our original ED. And it's a great facility, so a huge improvement over our previous establishment. Again, private rooms, so it makes it really nice. We also have these ortho carts that allow you to sort of keep all your supplies together. So weights for reducing distal radiuses, all your stockinette, plaster, and so forth, which makes it really nice to roll in and see your consult and get out. The other sort of attachment to our hospital is the battle building. So there's a picture of it lit up at night. Again, it's a sort of intermediate expansion, not quite as new as the expansion the ED's in, but newer than the hospital itself. And this is the home for our pediatric orthopedic clinics, as well as the basement floor, which is the outpatient surgical center. This is a breezeway that connects over. That's the GME office and the cancer institute there on the right-hand side of the screen. This is Neil on the way over, decided to model for us for a picture, but sort of set up similar to the main hospital. So this is our documentation area. This is where we check patients, again, surgical admissions. And then we have 12 ORs over there that are frequented by our hand, sports, and foot and ankle team. This is one of the a picture from one of the ORs in there. And lastly, so I think it's pretty clear that we have an awesome hospital, as well as Charlottesville being an awesome place to live. But I will say, just in closing, that really I can't express how awesome it is to work with the colleagues that I do. So as a rotating med student here, I quickly saw the culture of the program and sort of an environment that is very conducive to learning, and a sort of culture among the residents that is very approachable, really not malignant at all compared to other institutions that I had the chance to rotate at, and sort of a culture of fostering relationships and learning was really bar none. And I'm certainly privileged to be able to work with my colleagues. We get together quite frequently with all of our significant others. You can see a large group of us here out. And this is a pretty common occurrence. Again, all our significant others and ourselves get together and really have a good time. So I'm certainly lucky to be a part of this program, live in such a beautiful place.
Ian, thank you. That was awesome. I think some of the faculty here have never seen some of those places. Dr. Miller, that's what 6 East looks like. Did you know? I guess you've been on 6 East before, but that's what it looks like. And honestly, I haven't seen a lot of the new call room and stuff. So a wonderful whirlwind tour. That's the biggest problem in this whole situation, is not to be able to bring you guys into Charlottesville and our hospital, which was, for us, it's a huge deal to be able to show you guys what we have to offer here at UVA. So thank you, Ian. Again, you guys will have our email addresses. If you have further questions about Charlottesville or about UVA Hospital, you can certainly reach out to Ian or any of us, okay?
Absolutely.
So without further ado, I want to do something real quick. I'm going to try something and see if this works, okay? So we're going to probably try to utilize some polling questions here. And so I'm going to do a quick pre-test. We're going to be talking about ACLs tonight, okay? So, I'm going to launch a poll real quick and see if anybody in the audience and faculty, whoever wants to answer this as well as possible. So all the following are true except the ACL is composed of 2 bundles, anteromedial and posterolateral. ACL tears are more common in female athletes than male athletes. The ACL tear is the second most common cause of acute hemarthrosis after peripheral meniscus tear. The most sensitive physical examination finding is a positive Lockman. The most common cause of ACL injury is a non-contact valgus or rotational force upon landing. So let's see if you guys want to answer that real quick. We'll just go real fast. Obviously, everybody wants to hear Dr. Mark Miller. I mean, he's the reason why we're all here, right? All right, I'm feeling pretty comfortable about this, okay? So it looks like that was too easy of a question. So I think you guys did your reading. So let's try something a little bit harder, see how this works, okay? So I switched the order. The anatomical attachment of the ACL is on the medial wall of the lateral femoral condyle anterior to the lateral intercondylar ridge, the medial wall of the lateral femoral condyle posterior to the lateral intercondylar ridge, the lateral wall of the medial femoral condyle anterior to the lateral intercondylar ridge, the lateral wall of the medial femoral condyle posterior to the lateral intercondylar ridge, or the posterior aspect of the femoral notch in the 12 o'clock position. So let's give you guys an opportunity to answer that. Good. The polling stuff seems to be working pretty well. We have a little bit less. All right. We have a little bit less um, consensus on this. Okay. So it's the medial wall, the lateral femoral condyle, posterior to the lateral condylar ridge. And Dr. Miller's going to cover that during his talk, but I just want to kind of get a sense of where we are. Again, this is a pre-test. And our last question will be this. The most common concurrent injury with an acute ACL tear is 1, medial meniscus tear, 2, lateral meniscus tear, 3, MCL tear, 4, a lateral collateral ligament, or as like Dr. Miller likes to call it, a fibular collateral ligament, PLC tear, or a patella dislocation. Sorry, Mark, I know that was going to get you. In polling. All right, so this is a little controversial too. In fact, the correct answer is a lateral meniscus tear. Dr. Miller will cover in his talk as well. So the medial meniscus is more common with chronic injuries, but during an acute injury, it's more or less a lateral meniscus tear. So I just want to kind of get, I actually just kind of wanted to use a polling feature to see if we can make this more interactive. So far, so good. So without further ado, I'm going to go ahead and let Dr. Miller share his screen. You got it, Dr. Miller?
Yes.
It's my esteemed pleasure. When I was a visiting medical student here at UVA, I had the opportunity to rotate with Dr. Mark Miller, and it was one of the things that brought me to UVA. And honestly, he's been one of my mentors for as long as I've been in orthopedics. There's no better teacher in the entire world when it comes to teaching orthopedics and sports medicine, and nobody more passionate about what he does. And I think that when you're talking about the culture of UVA, it's faculty like Mark Miller that really, really defines where we are. And he is still going strong, and every single day he's still challenging us, both in conference, in the OR, and in clinic. And honestly, it's been a true pleasure to have you as my partner. I was your student, now I like to call you my partner. And without further ado, Dr. Mark Miller, let's talk about ACL reconstruction in 2020. The floor is yours, my friend.
Thanks very much, Winston. Can everybody hear me okay?
Yes.
Okay. So first of all, Ian, I want to sign up for that program. How do I do that? That was an awesome presentation. I've never seen the new ER. I'll have to get over there someday. So we're coming to a COVID-free zone, and I want you to shelter in place during this lecture, and we're going to go over just some fundamentals about ACL reconstruction and what's going on in 2020. We'll try to have a little fun along the way. So here are my disclosures. And I want you to kind of pay attention as we go along, because it's easy to get distracted and things like this. And there's a lot going on. And I know you're looking at this program, and it's easy to get distracted. And so pay attention if you will. So the question is, what are we looking for? What are we not looking for in medical students? I would submit to you that the gunner on the right is really not our ideal candidate. And likewise, maybe Joe UVA may not be either. So maybe somewhere in between, and maybe with a little more diversity. So what we're going to cover tonight is an introduction, then some anatomy. And again, I think for medical students, anatomy is the key. Every medical student that comes in my OR invariably is at the whiteboard drawing some anatomy and teaching us all the anatomy they should know. And so this is an important part of orthopedics. So I'm congratulating you for coming in orthopedics. And then also encourage you to study anatomy, because that's what it's all about. And you should know every anatomy. That's fair game for any OR you go into. And then patient evaluation is equally important. And so it's important to know the exams, and that came out in the pre-test. One of our residents that just graduated, fellows that just graduated recently, helped write a book on patient evaluation. And we went back and found all the original descriptions for the exams. And so I encourage you to look at that book as you go along. It's called Making the Diagnosis. Then we'll talk about surgical indications and then surgical technique. I'd like to say one slide on UVA research just to show you how passionate we are about our ACL research, and then we'll conclude. So by way of introduction, we'll start with an understanding of the ACL demographics. They occur in about 1 in every 3,000 activities, almost 100,000 new injuries a year, and 50,000 reconstructions every year in the US. Now look at this cartoon on the right. So if you haven't torn your ACL, you're more likely to go out in search of the double black diamonds, and maybe you'll be back here turning the other direction the next time along merry-go-round trail. Let's talk about anatomy. Anatomy, we talked about the bundles already. Note that the PCL is your PAL. So the PCL has an anterior lateral bundle and a posterior medial bundle. Therefore, the ACL is not your PAL, but therefore it has the opposite, anterior medial and posterior lateral bundles. That's a good way to remember it. Note that the anterior medial bundle goes more vertically and the posterior lateral bundle goes more horizontally. Therefore, the anterior medial bundle is more important for AP laxity and the posterior lateral bundle is more important for rotational stability. Here is a Freddy Food diagram showing that very concept, okay? So the bundles themselves are named based upon their location on the tibia. So note the red bundle is the anterior medial on the tibia. You can tell the difference between the medial and the lateral side because the medial meniscus is more C-shaped and larger, and the posterior lateral or the lateral meniscus is more semicircular and smaller. And so therefore you can see the anterior medial bundle in red, the posterior lateral bundle in yellow. On the femur, it gets a little confusing because most of the time when we're looking at this, we're looking at an inflection. So I'd encourage you to think about it in flexion. And again, the anterior medial bundle is more posterior, more vertical, and the posterior lateral bundle is more anterior and provides a rotational stability. So the history is classically the patient lands in valgus or hyperextension, and it's very common to get this mixed up with a patella dislocation. That's the great mimicker. And then female athletes, as that test indication suggested, are up to 5 to 7 times higher risk of ACL tears. Big deal. History, classically, it's a non-contact pivoting injury. The patient may hear or feel a pop. If they're a skier and the ski patrol brings them down the hill, they're likely to have an ACL tear. Patients will describe having an immediate effusion. They're unable to return to play, and they have recurrent instability. Sometimes the effusion is reduced by people putting ice on it right away. So beware of that finding may change if people are iced right away. The physical examination, the most sensitive test, as we alluded to in the pre-test, is the Lachman test. We'll show that in a minute. The pivot shift test, and that's really for AP stability. The pivot shift exam is for rotational instability, and it's difficult to do in the clinic, especially more than once, but we'll show you that as well. You also need to do a complete knee exam, looking at range of motion to make sure there's not a bucket handle tear with a locked knee, to make sure that all the other ligaments are stable, so you have an isolated ACL tear. The Lachman is simply an anterior displacement. Rotational asymmetry should be checked for posterior lateral concurrent injury. Here we see the Lachman. The proximal hand stabilizes the femur and the distal hand pulls in the tibia. That's the Lachman. This is subtle but positive here. And here we see a pivot shift. The knee is subluxed in extension and reduces in flexion. We go on to imaging, start with plain radiographs like everything else. We often get an MRI that's very sensitive and specific and will often be associated with a bone bruise we'll show you. And a CT scan is invaluable for revision ACL reconstruction, which is a focus of a lot of our research. Here we see some radiographic findings. This is a gone fracture or a lateral capsular sign, which now we know represents an avulsion of the anterior lateral ligament. The next image shows a deep sulcus sign, which is basically the area where a bone bruise occurs, and it's deeper than it should usually be. And then finally, we see tunnel positions, and this one is badly malpositioned anteriorly. I hope all of you recognize that. Here's the bone bruise, which is a classic contusion pattern in the center third of the lateral femoral condyle, the lateral aspect of the lateral femoral condyle, and the back of the tibia, slightly laterally. So this is the location of the so-called bone bruise. And this is how a bone bruise occurs. It's a temporary dislocation of the knee when you have that ACL tear. This is just very much similar to a Hill-Sachs defect in the shoulder with a shoulder dislocation and causes the deep sulcus sign in some cases. And again, as I indicated, CT scanning is essential for revision ACL reconstruction. There's a phenomenon called osteolysis that Michelle Q, one of our residents, and others are investigating, and we're reporting our results in very good, high-quality journals. So we have objective measurements for ACL instability. This includes the KT1000. This is merely an instrument that allows you to quantify the amount of Lachman exam. And so there's some drawbacks to it, but it's pretty good. It's pretty reliable when you compare it side to side. We don't have an instrumented rotation measurement. We need a rotationometer, and the investigators at Pittsburgh are working on that, and they have a iPad type device that they're developing. What's the natural history of ACL reconstruction or ACL tears? The bottom line is that if you leave it alone, it'll increase your incidence of meniscal tears and cartilage tears, and therefore probably arthritis. So when we're looking for patients who are physiologically, not chronologically young, and they need to be active and want to return to those active sports, and they do better if they have increased laxity that we can correct. So how do you reconstruct the ACL in 2020? This is not always the answer. The internet doesn't always have the answers, and you can watch as many videos as you want, but sooner or later you got to come to the OR and practice. Nothing works as well as practice in our profession. So what grafts do you pick? Well, we know that synthetic grafts historically have failed. Allografts or donor grafts have a really high risk of failure, up to 5 times the risk of failure in the West Point study. And then we therefore go with autografts almost exclusively. We use patella tendon autografts quite a bit, but these other grafts are options as well. So each graft has benefits and risks. The patella tendon is very good. It's faster incorporation. It's a little bit more stable, but it can be associated with anterior knee pain. Hamstring grafts are stronger biomechanically, but the fixation can be an issue. And some of us are migrating more and more to quadriceps tendon, which is really useful for revisions in my setting. Let's spend a minute looking at this picture, which is very confusing to most people when you first look at it. This has to do with tunnel position, which is the most common mistake in ACL reconstruction. So on the femoral side, note that that middle graft is where you want to be. That's the anatomic location. And so with both the extension and flexion, it stays the constant stress on it. It doesn't elongate, and it doesn't become lax. So that's where you want to be. So if you have a graft that's too anterior, it's going to be lax in extension and tight in flexion, and vice versa. If you have graft too posterior, it's going to be really tight or even rupture in extension and be really lax in flexion. So you want to be in that middle ground. And you can't get there from a transtibial approach. So many of you may be in programs where they're doing transtibial approach. That doesn't work here. We're doing independent femoral tunnel drilling, and we'll teach you various methods to do that. So the question is, where do you place the tunnels? If you look from an anterior lateral portal, you can't see the locations as well. But if you look from an anterior medial tunnel, you can all of a sudden see the entire lateral femoral condyle, the medial aspect of the lateral femoral condyle. And you can pick and choose where you want to put your graft. So the question is, where do you put your graft? What do I recommend for your tunnel position on the femur? I recommend G, which stands for good. And that's where we put it. Here's, you put a pin in and retrograde it. You can see exactly where that is on intraoperative fluoroscopy. And it should be below Blumenstadt's line and about the junction of the 3rd and 4th quadrants. On the tibial side, if you look from a standard lateral portal, you can't get the 50-yard line view that you can from a more superior anterior lateral portal. And here you see the ACL footprint after it's been debrided. Here you see from that upper portal looking down on it. Again, I like to be slightly anterior, and G is good. And so I've been using fluoroscopy for many years. We have several papers on this, and this shows excellent location of both the pins that can then be drilled for our ACL reconstruction. So it's time for surgery. Let's talk about where we place our tunnels. One of our former fellows helped with this 1-minute video. We start arthroscopically. We make an accessory medial portal. We choose our location on the femur. We hyperflex and then drill in that location we picked and retrograde that pin. Now we can drill our tibial tunnel. Right there, comes up in the anterior part. We checked fluoro. Again, we talked about where we like to be, right in front of that eminence and about the junction of the third and fourth quadrants. Retrograde our pin back, over drill it. Clear out that tunnel, pass a passing suture, drill the tibial tunnel over the guide pin. Save bone graft here if you need to, and there's your 2 tunnels. All in 1 minute. Amazing, isn't it? And now we can pass our graft and fix it with an interference screw for a bony fixation or some type of cortical button for a soft tissue fixation. The postoperative management, early motion is key, especially extension. I don't use braces unless I'm using meniscal repairs or other ligament repairs. We progress pretty quickly with weight bearing unless they have cartilage or meniscus repairs. And we try to get them back to running at 3 months. Now it's probably delayed to 4 months or 5 months because some of our studies have shown that it takes longer than we thought to get ACLs back. And so we used to say 4 to 6 months. We now say 9 to 12 months. Here is a figure that Steve Thompson and Brian Warner and I put together for the most current edition of Review of Orthopedics. This is what I call a composite figure, and it shows a variety of things all in one figure. I love composite figures. And so we can see that there's all kinds of problems that can cause ACL failure. The most common cause, as I indicated, is inaccurate tunnel placement, especially on the femur. But lots of other problems can exist as well. For example, if you malplace an interference screw, it won't interfere. If you malplace a cortical button and doesn't engage the cortex, it won't work. If you miss concurrent injuries, such as this ramp tear, you will have a loss of a secondary stabilizer and increased stress on your ACL graft. If you fail to recognize and repair a meniscal root, the same thing will happen. Sometimes you need to augment your reconstruction. We're doing that now with the so-called modified Lemaire. You sometimes have to check the tibial slope very carefully because you may need to correct that as well. We're studying this as well. And speaking of studying, we have a whole host of ACL studies that we have done and are working on. And so if you're interested in ACL research, you need to come join us, and we can make another list on another page. So we're riding off in the sunset. If you like ACLs, come join us at UVA. And I think Winston's about to give me the hook, so I think I'll get this concluded here real quickly. I'd like to thank and recognize the 2 teams that we take care of UVA, both UVA and James Madison University. So thanks very much. Welcome to UVA. We'd love to have you. Thanks, Winston.
Dr. Miller, that was excellent, as I would expect. Again, one of the, I think the lifeblood, again, I use that term a lot with our program, not only as our residents, but our faculty is just so engaged. I'm part of the sports medicine division, and it's, for me, a lot of growth of my career has been with these faculty members who both helped train me and now continue to mentor me throughout all of this. So I'm gonna give a quick shout out to my partners. I see in the top right, Brian Warner, who is my partner, who takes care of James Madison University Athletics. Mark Miller, obviously, who just gave the talk, and Dr. David Diduck, who represents 4 or 5 of our faculty. Steve Brockmeyer's on vacation this week. All right, so, and then Keith Bachman is here. He's going to be filling in for Steve Brockmeyer as our 5th room. So I sent you guys all kind of some survey type questions after the first session about how you guys want to make this more interactive. And a lot of people thought about doing breakout rooms, and so we're going to give it a shot. So in the interest of full disclosure, this is the first time I've ever done breakout rooms on Zoom. Now I've done probably 120 Zoom conferences so far, but this will be the first time I've ever tried this, okay? So please bear with me. The goal of this is to foster some interaction. I've got a case. Every single room has the same case. Each room is going to be a different faculty member and a different resident to kind of help guide you through the case. And so it's 8:40 right now. I swore I would never let this thing go past 1 hour. So right around 8:55 or so, I'm going to close the breakout rooms and see if we've learned anything about ACL tears. Maybe have some further discussion at that point. Okay. I would ask that all the students would put their video on so we can see what you look like, and then maybe we can foster some discussion here. So if this thing completely screws up, I'll try to get reorganized, but I've assigned all y'all to rooms. Let's make sure everybody's assigned, and I'm going to open the rooms, and then each resident will start sharing their we're going to start sharing their screen. We'll go through a nice ACL case, nice and simple. Okay. So I'll talk to you guys at 8:55. Oh, I guess you guys have to join. All right. Emmanuel, let's see who's in my room. I have nobody in my room. Do I have anybody in my room? I got to join. Join, go out.
You're still muted, Winston.
So Winston, that went pretty good. I like those rooms. That was pretty cool.
Yeah, I've never done anything quite like that before. I have some ideas. I kind of want to make sure that I can't assign you guys to a room before you actually log in. So otherwise I would have pre-assigned you and kind of given you a heads up of who you're going to be with. But we had a great time in our case, just talking about things. Any take-home points as far as that case goes? Dr. Dieduk, maybe? Oh, you're muted, Dave. Let me unmute you. Hold on.
Oh, am I muted?
You're unmuted. Go ahead.
Yeah, I thought your meniscus repair technique was pretty sexy. The crisscross there, I haven't seen that before.
Yeah, well, to be honest, I think Dennis was there in the case, and we put one stitch kind of obliquely. I'm like, oh, I can't leave it like that. So we put another one that made an X, but it ended up reducing that meniscus tear. What I would point out to everybody is that's the area the meniscus gets crushed between the condyle and the tibial plateau. And so always look for a tear there in acute settings. So anyhow, so that's pretty much all we had for sports medicine. Again, I want to say thank you to Dr. Mark Miller, again, an icon in ACL surgery, Dr. David Dieduk, who was also my mentor and taught me a whole lot about when I was a visiting medical student here at UVA. Dr. Miller and Dr. Dieduk were the two kind of the pillars of sports medicine here. We've added a third pillar, Dr. Brian Werner, who was actually my chief resident when I got started. So you can see that things come full circle. And again, Dr. Steve Brockmeyer is out on vacation, otherwise he'd be here. I want to give a special shout out to Dr. Keith Bachman. How did your room go, Keith? Did you guys do a tibial eminence repair?
Yeah, we kept everything in the epiphysis. It was all epiphyseal fixation. We're good.
So, and again, thank you to Dennis Chen who put that case together. So again, like I told you guys, I don't want this ever to go past 1 hour because everyone knows in a virtual curriculum, you guys have other things you want to be doing. I just want to say thank you for coming. And any questions from the audience, you can always email me. I'll send an email out after this, just getting some more feedback from you guys. But otherwise, we'll see you guys next week, okay?
Go Who's.
Absolutely. Thanks again, Dr. Miller.
Go Dukes. Go Dukes.
Go Dukes, yeah. Brian, you have your ring? Show your ring.
Oh, no, I took it off, man. My hand's so heavy from all the championship rings. It's hard to hold them all.
I got one.
Oh.
I got mine sitting upstairs. Ah.
There's a natty.
I got my football here, so. All right, guys. I'll talk to you guys.
All right.
We'll see you next week.